Give everybody a minute to get connected. Happy Monday, and thank you for joining us today. We are excited about this program, and we're going to have, it looks like quite a few of you joining us. So I'm going to go over a few bits of housekeeping before we do. My name is Anissa Mitchell, and I'm with Parkinson and Movement Disorder Alliance. You're joining us today for Lunch with Docs. And we are going to be talking about atypical Parkinson's. And if you want to ask questions of our speaker today, Dr. McFarland, I want to invite you to hover down at the bottom of your screen where you can enable your little chat box. You'll see like a little bubble in the middle that says chat, and open that up and let us first of all shout out where you're coming from. And then please feel free to chat your questions throughout the program. And then at the end of the program, after Dr. McFarland has finished with his slide presentation, then we'll go through some of your questions. Some of them may be answered through his presentation. I will try to scroll around and keep track of those, and then we'll ask those of Dr. McFarland. You are going to remain muted through this program just so we don't pick up any background sound. And actually, we have quite a few people joining us today, but we definitely want to hear from you. So it's great to see where everyone's coming from. See Maryland and Florida, California. So welcome, welcome everybody. So I'm going to introduce you to our speaker today. This is Dr. Nikolaus McFarland, and he is with the Norman Fiksel Institute for Neurological Disorders, and he is also a professor of neurology in the Movement Disorders Division at the University of Florida. He's in Gainesville, and he is an expert in atypical Parkinson's. He directs a comprehensive multidisciplinary clinic research program for atypical Parkinson's disorders. So he is an expert in this field, and we are excited to have him share this expertise with us. And I know he has a fantastic presentation. So first of all, welcome, Dr. McFarland. Thank you for joining us.
Thank you.
And I'm going to pass this off to you now, and we'll let you get started.
Great. Thank you so much. I appreciate this opportunity to talk to everyone about the Parkinson spectrum and atypical. Let me share my screen with everybody. There we go. Again, thank you so much for inviting me to give this talk. I'm looking forward to this, and hope it will provide some information and generate some questions for all of you as well. I'm happy to take them at the end of the talk and throughout. I think they're going to be collecting things. So as they mentioned, I am an associate professor of neurology here at the University of Florida, and I direct the atypical Parkinson program here that we started about 10 years ago, and it's been growing ever since here in Gainesville, Florida. I thought I would just take a second here to, let me show you a little bit about our Norman Fiksel Institute. That was on the first picture, actually. We have really grown over the last year, and we just opened up our a new site here off of I-70, and we are increasing our volume here. We've added several faculty over the past year, and we added 3 of our new research faculty listed on this particular slide. And we have a number of centers here. We are a Parkinson's Foundation Center of Excellence and a Cure PSP Center of Care, and I won't go through each one of them, but we really enjoy our center here, and base it really, the patient really is the sun, and we have this multidisciplinary model that we have here at the center to provide comprehensive care for patients as well as research opportunities. Just to give you a view of our really nice new center, we have a beautiful new facility shown here, kind of with our waiting room and a back area actually for people to sit in the sun. We have a huge sort of multidisciplinary sort of rehab center shown here in this particular slide, with an outdoor area where we can look at patients walking on different surfaces, including a golf course, of course, being in Florida shown here. And we have a automated digitized mat where we can look at people's gait and do a gait analysis as well, just off the side of our waiting room shown in this. And of course, as I mentioned, we offer all of our patients opportunities to participate in the latest research that's going on, including just clinical trials that are happening in various disorders, including the atypical Parkinson disorder shown here. So I don't want to spend a lot of time on that. What I really wanted to talk about today was really this Parkinsonism or Parkinson spectrum, and I'm going to focus today more on the atypical Parkinson disorders in particular. So you'll see throughout the slides some famous people who are affected by some of these diseases. These are folks affected by Parkinson's disease and Parkinson disorders on some of these slides. I just want to take a minute just to step back and kind of talk briefly about the burden of Parkinson's disease in our society. And I'm sure you've seen things on the web and maybe heard this over and over, but you know, the burden of disease is growing. And this slide is really evident of that. Now, I think you can kind of tell from the slide that the burden of Parkinson's disease is huge and expected to more than double. In the United States alone, we have about 1 million people who suffer from Parkinson's disease. Clearly here on this slide, you can see that China has a huge burden as well, including Europe too. But the key thing really here is to look at the increase in the number of patients. It's really huge. And the economic burden, the burden on our health system is only going to increase. And we need to know a lot more about these diseases. And of course, find better treatments and eventual cures. So what are the Parkinson syndromes or Parkinson disorders that I'm talking about really? You may have heard this term Parkinsonism thrown at you if you are a Parkinson patient, and maybe you understood it or didn't understand it. Well, it really is a nonspecific term. It's more of a descriptive term. And on the right, you can see some descriptive features of this. So Parkinsonism really refers to a constellation of symptoms, including tremor, particularly a resting tremor in Parkinson's disease, rigidity or stiffness, slowed movement, which we call either bradykinesia or akinesia, or a lack of movement, and postural instability. I tell many of our students just to remember the acronym TRAP. There are many more features of Parkinsonism, but I want you to understand it's a constellation of symptoms and it's a descriptive term, something that we as physicians use to describe what we see in the clinic. Now, by far the most common cause of Parkinsonism is Parkinson's disease. As I mentioned, there's 1 million patients alone in the United States with Parkinson's disease. However, about 10 to 15% of what we see in our clinics is not Parkinson's disease. Some of these are we call secondary Parkinson disorders, and I'll mention them briefly, but other ones are primary Parkinson disorders that fit into what we call an atypical category. They have features of Parkinson's, and I'm going to talk more about it, but they have sort of plus features that I'll mention too. So these are also named Parkinson plus syndromes too. I'm going to mention really, and I'm going to talk sort of synonymously with what we call the pathologic or the neuropathological diagnoses. More and more in our clinic, you may hear terms thrown around that kind of reference proteins or that sort of accumulate in the brain, things like protein inclusions. You may hear terms like synuclein, Lewy bodies, tau disorders, amyloid, and there are even a number of other proteins that we see. These are proteins that we see on basically molecularly, we see them on pathology, and we have to see them on slides. We can't really see them grossly in the brain. Okay, so I'll talk a little bit about those because they kind of define the diseases more and more these days, and they're increasingly relevant because this is really where we're going to be starting to target the disease and not just the symptoms. So I'm going to start with Parkinson's disease briefly as an example. So as many of you probably know, the hallmark of disease is the loss or progressive loss of dopamine cells in the brainstem of the brain, in the back of your head. This is just a pathologic pictures on the right showing two examples. On the right is sort of a slice through the midbrain, including what's called the substantia nigra. That's this black substance shown here. It's not really black substance. It's actually, these are nerve cells that contain melanin. Melanin is a pigment that basically colors your skin, and it's found within the dopamine cells. And you can see on the left-hand slide, this is a slice through the brainstem showing loss of those pigmented melanonic neurons. Down below are a couple of pictures that you can see. This is actually a neuron, a nerve cell, and you can see sort of these brown or blackish dots that are shown in the cells. That's actually the melanin that gives the pigment. So this is a dopamine cell. This is the cell body shown here on the left. And then on the right, where there's an arrow here showing a Lewy body, this is basically a foreign player okay? This is that proteinaceous inclusion that we call a Lewy body that's enriched in alpha-synuclein. So the real second pathologic hallmark of Parkinson disorders, or Parkinson's disease in particular, is the presence of Lewy bodies that we see only pathologically at the microscopic level. On the right is just a stain that we can use on slides that can label those alpha-synuclein or Lewy bodies. The cell, it's actually this brown stain shown here. Now, this is not unique to Parkinson's disease. We see it in other Parkinson disorders, in particular, another one I'm going to talk briefly about, multiple system atrophy. We see them in Lewy-Body Dementia, hence the name Lewy-Body disease, as well as familial Parkinson or hereditary Parkinson disorders, at least some of them. So this is one pathologic feature that we see. Now, there are a lot of different thoughts about what are the cause of Parkinson's disease. I get this question all the time. And basically what I tell patients really is that, you're born with a set of genes. And of course, we think of Parkinson's disease and it's generally a sporadic disorder, though we know there are familial forms. We know that some people have a family history, for instance, a father or mother, although there's no strong family tie to them, but we know that might increase your risk. So the genes do play a role. They essentially load the gun, and we think that there's some sort of environmental cause that may trigger the onset of these sometime later in life. So on the left of the slide are a number of different genes. I'm not going to go through each one of them today that have been associated. Some are familial causes, like the synuclein gene shown up here called SNCA. Some are risk genes. For instance, I'll point out a couple others a little bit later here. There are lots of environmental factors that are thought to increase risk or maybe cause Parkinson's disease or the onset. These go from various toxins, pesticides. There are even some things that may reduce your risk. For instance, coffee intake is really the caffeine that may have better effects on men than it does at women. There's a number of things I list here. So just remember that it's sort of those genes you're born with, and then maybe some trigger that we're beginning to learn about more and more. This slide just shows you an example of what we know about different genes and the risk for Parkinson's disease. And I'm only going to point out a few. This is what we call a Manhattan blot. It's just giving you on the left-hand side the frequency, and then these are genes on the bottom that are listed based on your chromosomes. We all have 22 pairs of chromosomes, and they're listed on the bottom here. And I'm going to point out a couple of genes. Alpha-synuclein was the first gene associated with Parkinson's disease. So that's listed here, but it's actually an uncommon cause of familial Parkinson's. Probably there's another gene called tau, which I'm going to talk about a little bit later in terms of tau disorders. It's a risk factor for Parkinson's disorders in general. This is another gene that you may hear more and more about. And if you've gone out to do gene studies, for instance, with 23andMe, you may hear about this LRRK2. It's the leucine-rich repeat kinase 2 gene. That is probably the most common gene that is associated with sporadic and even genetic forms of Parkinson's. It's a risk factor, not necessarily a cause. More often found in Ashkenazi Jewish population. There's another one called glucocerebrosidase gene as well. So genes play a role. Sometimes the cause, sometimes just a risk factor for Parkinson's. So there are a lot of diseases that cause Parkinsonism or symptoms that mimic Parkinson's disease. This is just the soup of different disorders that I list here, and I've kind of highlighted some larger than others, like Parkinson's disease in the middle. I'm not going to talk about all of these clearly, but I am going to highlight a few of the more common disorders, atypical disorders here. I'm going to kind of talk a little bit about the diseases, and I want to kind of just show you this graph on the left here as how physicians or myself kind of think about these Parkinson's disorders. So we think of Parkinson's disease as being the primary cause of Parkinsonism. There are secondary causes like stroke, infectious causes. There are drugs. There are many drugs that can cause Parkinson-like things. NPH stands for normal pressure hydrocephalus, or fluid on the brain, that can cause Parkinson's-like symptoms too. And then there are a bunch of hereditary causes. I'm going to focus on these atypical disorders listed below, and I'll go through them individually. On the right, I just want to show you this to remind you that more and more we're thinking about these diseases, and we're thinking about the molecular and neurodegenerative causes of the disorders, because we want to target these in the future to target the disease and not just treat symptoms. So we do put these into different families. For instance, synuclein or Lewy body disorders, we think about Parkinson's disease, dementia with Lewy bodies, multiple system atrophy. There is a family of tau disorders. This includes Alzheimer's disease, by far the most common neurodegenerative disorder that we see worldwide, really. But among those, there's some rare things that I'm going to mention that cause Parkinson's: Progressive Supranucular Palsy, or PSP, and Cortical-Basal Degeneration. There are other ones listed here. Amyloid, of course, is part of Alzheimer's disease. And then this growing sort of group we call TDP-43, that's another protein that's normal in the brain that seems to go rogue, that causes other disorders called, for instance, ALS, FTD. So it's associated with these different disorders as well. So we start to group these, and it matters in the sense of the research and how we may target these in the future. Okay, so I'll come back to that from time to time. So one of my jobs as a neurologist, an expert in Parkinson's, really first is to ask, when I see a patient who has Parkinsonism, is it other than Parkinson's disease? What am I really looking at? So there are some sort of, I call red flags, and so these are just a few of them. Number one really is it rapidly progressive? So Parkinson's disease typically is a disease of 20, 30 years. It's slowly progressive. Atypical Parkinson's disorders tend to be much more rapidly progressive, on the order of twice, if not more, even more rapidly progressive. Early prominent speech or swallow issues, early balance things, so freezing, getting stuck when you walk, and even frequent falls early on in the disease. And I'm talking the first 5 years. Tremor, so as I mentioned in the beginning, the typical tremor in Parkinson's disease is a sort of a pill rolling resting tremor, okay? Tremor can manifest in many different ways. So it can be present with action when you're eating or when you're drinking or just reaching for an item. So, but the typical tremor in Parkinson's is one that is seen at rest. For instance, when you're just doing nothing, maybe sitting around watching TV. So when we see a mixed tremor or a tremor that's not present at rest, we have to wonder, is this something other than Parkinson's disease? And then lastly, although not the most important really, is the response to levodopa. So levodopa is a supplement that we give Parkinson's patients, the most common and the best effective treatment for Parkinson's disease. Levodopa supplements the brain's dopamine. It's a precursor for dopamine. And patients need to get a good trial, a reasonable trial of up to, I say, roughly 900 milligrams or 1,000 total in the day before we say it's really failing. But for those patients who don't get a good response, now about 20-25% of Parkinson's disease patients, some of their symptoms don't respond. Doesn't mean you don't have Parkinson's disease, but it should raise a red flag to a clinician to wonder, is this really Parkinson's disease, or am I looking at some other disorder? Now, I mentioned in the beginning that some of these atypical Parkinson's, we used to call them, we're called Parkinson's plus disorders, because sometimes they have Parkinsonism plus other features that are unusual. So some of those other features include gaze palsy, so difficulty looking up or down, okay? So this is volitional sort of gaze, looking up and down. Limited eye movements. We see that in some of these disorders called PSP, cortical basal. Autonomic symptoms. So these are things that we don't think about, bodily functions that are actually controlled by our central nervous system. These include things like control of our blood pressure, bowel function, sexual function, sweating. So these can be impaired in Parkinson's. You know, a lot of Parkinson's disease patients have problems with constipation, getting full quickly, having problems with urination, but to a different degree here in atypical disorders. Cerebellar features are features of coordination, okay? Significant problems with coordinating movement. Likewise, early cognitive or memory thinking impairment leading to dementia. If that occurs within the first few years or within the first 5 years, that's really unusual for Parkinson's disease. Most Parkinson's disease patients, if they do develop dementia, develop it late in disease, not early on. So that would raise sort of the spectrum for something potentially called dementia with Lewy bodies. Now, of course, if you have early psychotic features, hallucinations, you may be delusional or odd thoughts, that's also unusual for Parkinson's disease early on. Now, there are other things that we see. So apraxia refers to learned behaviors. Myoclonic refers to jerky behaviors. And this alien syndrome, sort of a limb that does something that you aren't really have very much control over, seems to do something on its own. And that's something we see sometimes in something called cortical basal. And I will talk about that briefly. Okay, so these are some things that we are looking for in Parkinson's disease to clue us in maybe something else is going on and we need to do a little bit more evaluation. So again, when I hear basically hoofbeats, I'm thinking horses, so I'm thinking Parkinson's disease most of the time. By far, nearly 90% of what we see is Parkinson's disease. And it's not a hard diagnosis, though sometimes the symptoms are not classic. Sometimes we see zebras in our clinic. And of course, we have those rare patients that are, essentially the unicorns. And we need to do much more analysis in patients. So I'm going to talk more about the zebras, not necessarily the unicorns today. All right. And I'm going to start with the most classic atypical Parkinson syndromes that we see. For those of you who don't know these folks, Dudley Moore had progressive supranuclear palsy, and this is one of our Iron Chefs who suffered from multiple system atrophy and passed away. So a number of folks get affected by this disease. So for the atypical Parkinson syndromes, I'm going to divide them up, okay? Based a bit on their pathology, I can kind of group the brain disorders here and the predominant protein problems. So I'm going to start with what we call the frontotemporal disorders, or a spectrum of frontal temporal disorders. And this includes both progressive supranuclear palsy and cortical basal syndrome. But there is a spectrum disorder. So, think of the rainbow here. This is a really nice figure for a Nature Review paper that I like to look at. Just gives you kind of a view. These are, again, those abnormal proteins that we see. So focus more on the tau circle here. There is overlap in pathology, but I really want you to focus on the right, these disorders, CBD, or cortical basal degeneration, and progressive supranuclear palsy. These are tau disorders, but they are part of a spectrum of disease of tau disorders. Tau actually is a protein that's normal in the brain, associates with microtubules. These are structural proteins. It just happens to become phosphorylated. It tends to aggregate and causes problems with those microtubules. In brain, it forms aggregates essentially in these diseases. It also causes the same thing in Alzheimer's disease, but it can vary on how it forms these aggregates and cause different disorders. We don't really understand that quite yet. That is one of our major goals in targeting treatments and understanding how patients get one disease versus the other. So I'm going to focus first on the most common atypical disorder that we see in our clinic, at least that I see up here, and that is first progressive supranuclear palsy. So on this slide, I show you kind of a little bit about the prevalence and incidence. It's about 6 out of 100,000. So we're talking about 1 million Parkinson's disease patients. We're really talking about 20, maybe 30,000 in the United States who suffer from progressive supranuclear palsy, abbreviated as PSP, a lot easier to say. So it's a relative rare disorder, but common enough that we see it frequently in our clinic. Average onset of disease is similar to Parkinson's disease, so basically around the early 60s, so 63 to 66, and duration of symptoms from disease onset can last 6 to 10 years on average. Now, of course, can vary from very short to quite long. I have patients up to 19 years still with disease. So this is just an average listed shown here. But as compared to Parkinson's disease, where I said 20 to 30 years, this is nearly half, if not a third sometimes. So this is a rapidly progressive disorder, unfortunately, and quite devastating. So what are the hallmarks of this disease compared to Parkinson's disease? Well, hallmarks of this disease are early problems with balance and gait. Many patients begin falling within the first couple of years. So on the right, I show you a graph, another graph. This is just months on the right, shown here on the bottom. So an average Parkinson's disease patient generally doesn't start having falls or frequent falls for at least 5 years into disease. For atypical disorders, it's earlier. So we have Lewy body disease, we have multiple system atrophy, I'll get to that, vascular Parkinson's, and then there's PSP. So average onset is roughly 16 to 18 months. So very early in disease. Patients with PSP often fall backwards, although they can fall in different ways, but backwards falls are quite common relative to Parkinson's disease. So Parkinson's disease patients tend to shuffle, they lean forward, and they tend to fall forward, although again, that's just a generalization. So, but backwards falls are something that's fairly common in PSP and leads to lots of different injuries, fractures, head injuries. Another key feature, hallmark, is gaze problems. So being able to look up and down. You don't really think about this very often. I'll mention a little bit later here, a second, in the next slide. But being able to look up and down is really critical in the sense of following what you read, following the lines, being able to see what you're eating that's in front of you, but down in front of you. So being able to look down in particular is a part of progressive supranuclear palsy. So there are a lot of different symptoms in this. When the eye movements become so limited, patients end up looking like they have this surprised or stared look. Movements like in Parkinson's disease are very slowed, so become much more so even early on. Patients have sloppy eating habits because they can't see what they're eating. I have a lot of different visual complaints. They have mood issues, labile mood, for instance, laughing and crying, sometimes inappropriately, and even late onset sort of dementia or cognitive impairment in this disease. So a lot of different features actually, but just remember early balance problems and visual symptoms. So talking about eye or visual symptoms in PSP, there's a lot. So it's not just the impaired looking up and down shown here, and voluntary, eye gaze. Patients try to lift their lids out of it rather than moving their eyes to look up as well as down. It's because they don't blink very much, they end up having dry eyes and blurred vision and eye discomfort. Double vision is not uncommon. Difficulty reading is not uncommon as well. Some of the patients actually have trouble closing or opening their eyes. Opening eyes can be a learned problem. It's actually a behavior. Some patients actually have spasms of their eyes that actually lead to them being closed involuntarily, closed so much that it causes functional blindness in some patients. So there are a lot of different symptoms that involve the eyes in PSP that can be very much impaired. So I do want to take a second and just mention that PSP is really not one disease. There is quite a bit of heterogeneity. There is a classic way, and I'm mainly talking about the way it classically presents. This was written about over 60 years ago now, called Richardson syndrome. That's just another eponym for progressive supranuclear palsy, but that is the most common form of PSP that we see. It involves tau protein pathology, but this disease overlaps and looks very similar to other diseases and has different ways it presents. Sometimes it presents early on, just like Parkinson's disease, and we call it PSP Parkinsonism. You can show here, some patients present not with early falls, but with a lot of freezing or hesitation. And that is the primary problem that they have, is just this being stuck when they walk. Other patients have an overlap with cortical basal. I'm going to mention that next. There's early dementia patients who have behavioral problems and some other rare forms of PSP. But just want you to know it's not just one disease, and there's overlapping pathology, but many of these patients progress, and they progress from patients that look like Parkinson's and have just a suggestive calm, like PSP syndrome, to more later on like classic PSP, which is quite devastating for many individuals. So let me take a minute just to talk about some of the pathology. So again, I'm going to emphasize this is a tau spectrum disorder. So the problem is the tau protein. It basically aggregates both in neurons and supporting cells, which we call glial cells. Glial cells are there in the brain. They're all throughout, supporting the nerves. A classic sign that we see pathologically is this astrocyte. There's a lot of degeneration in the brain involving a number of different structures shown here, mostly midbrain atrophy. when I'm talking about midbrain is right in the middle of the brain at the top of the brain stem. And I'm going to show you an MRI here in the bottom here, and I want you to focus. This is actually your spinal cord coming up, and this is the brain stem. And there's two areas shown here, the pons and the midbrain, right at the top of the brain, and the back of the brain here is called the cerebellum. This is a Parkinson's disease patient. This is a PSP patient as compared to a multiple system atrophy. One thing you might notice is this midbrain is extremely small compared to this rest of the brain stem, compared to MSA. Some people actually look at this side view of the middle of the brain, and they say it looks a little bit like a hummingbird. So this midbrain looks beaked, and you may hear this hummingbird sign. There are a number of other signs that radiologists use to describe PSP or the midbrain atrophy. Some people look at it the Mickey Mouse sign. There's other different signs that we see. But this is probably a common thing, and you may, if you have a loved one that unfortunately happens to suffer from PSP, this may be something that a radiologist may pick up and you'll see on a report. And it can actually be helpful to diagnose this disease, although not 100% diagnostic. So let me turn to the other tau disorder, and this is actually even more rare. It's about 10 times less common than PSP, and that is cortical basal syndrome. Now, you may have heard this go by a different name, cortical basal degeneration. That's a really specific term. We now kind of have broadened this out because we now know it's not just all cortical basal degeneration, it's actually a syndrome. Mean onset here again is very similar, sort of early 60s, and prognosis is very poor, unfortunately, with disease duration about 6 to 8 years, but varies, of course. This disease involves both the same areas that Parkinson's involves, which we call the basal ganglia, but also involves the higher, we call cortical areas of the brain. We call the cortex. This is where your higher reasoning is. And it has overlapping features with many other types of dementia, ranging from Alzheimer's disease to frontotemporal disorders to even progressive supranuclear palsy. And the two almost, virtually overlap each other in a lot of ways, partly because the pathology is quite similar. So for this disease, the most common presenting feature is really asymmetric limb dysfunction or clumsiness. So basically either the left or right limb. A patient tends to present to me and says, my hand is not working anymore. It's not doing what I want it to do, and it's starting to make this funny posture. That's entirely different than what we see in a Parkinson's disease patient who usually complains, I got a little weakness, I got some tremor or stiffness. Now, certainly stiffness is part of the disease, but limb dysfunction is really not part of Parkinson's disease, not true limb dysfunction. The term we use as neurologists is something called apraxia, and I'll come back to that, okay? So with this disease, very commonly, it's very markedly asymmetric. One side of the body tends to be more affected, at least in this classic presentation. So maybe the left or the right side starts. We don't know why one or the other. There's a lot of rigidity. There's a lot of abnormal posturing, which we call dystonia. Sometimes it's pulled up the arm. And the tremor is atypical. So tremor in this case can be more coarse and mixed, both at rest and with action. Speech and swallow issues can occur early on. There's also eye gaze problems, and then a little bit later, balance problems too. Now, on the flip side are these cortical signs, basically those higher cortical issues. Some patients can present with language problems. I don't mean just speech, the mechanical form of speech. What I mean is language, being able to find or form the words, okay, comprehend what you're saying, okay. Limb or speech apraxia refers to learned behaviors. So having trouble using the remote, having trouble actually holding a utensil, such as even knowing how to use a fork or a knife, is what we call apraxia. Now, alien limb requires a little bit of explanation. So alien limb is a limb that basically does something or takes on a posture of its own. And many patients say, I'm not doing that, it's doing it on its own. And it may be something another family member looks at. And it's not just limb elevation, but it's sort of a limb doing something out in space. Sometimes the limb will reach over to the other arm and sort of interfere with activities. This is basically what we call an, quote, alien limb. Some patients also have jerking movements that are very rapid, which we call myoclonus. That's actually something that's involving the cortex, so that's a cortical pathology. Some patients have loss of sensation. It's not numbness, but actually loss of discrimination of things in their hands. And of course, dementia, since we're talking about cortical issues. Unfortunately, with this disease, response to levodopa, the classic Parkinson medicine, is often poor, if not zero in many patients. It is a tau disorder. I won't go through this slide in general. The one thing I will point out really here is the brain scan can sometimes be helpful as there are cortical changes. This is a MRI picture of the cortex a little bit higher on. The folds of the brain should be like the top here. And where they point the arrows, you can see there's a lot of loss of brain. This black is loss of brain. And there's very thin, we call the cortical layer of the brain shown here. So I gave you two examples of atypical Parkinson disorders in this tau pathology family, PSP and cortical basal syndrome. They are rapidly progressive. They sound terrible. I don't want to give folks the fact that they feeling that there's nothing that we can do for patients. In fact, there is quite a bit that we can do to treat patients with these diseases. As they are Parkinson disorders, all patients should get a trial of levodopa. It is the best medication for Parkinson disorders. Higher doses might be needed, although you have to watch out for side effects. Dopamine agonists like rotigotine, ropinirole, pramipexole, these are dopamine agonists. Generally don't do a lot in these disorders. To treat other symptoms like the abnormal posturing, sometimes botulinum toxin as an injection into muscle groups can relax those muscles, even muscle relaxants. We can treat the muscle jerks as well. So there are treatments for this disease. They may not be perfect, but there are treatments. Sometimes we can treat the memory or thinking issues, but the memory drugs that we have for Alzheimer's don't generally work very well. Mood. So there's much more than just the behavioral and motor symptoms in these diseases. Mood issues should be addressed. Treat the depression with antidepressants. There is medication for mood lability. For instance, something called, the actual brand name is Nuedexta. It's actually Dexa. It's a cough medicine with quinine in it actually. That's called Nuedexta. It can treat some of the labile, laughing and crying. And of course, we have to use our multidisciplinary team, our allied healthcare workers. Supportive therapy is critical in these diseases. Getting physical, occupational, speech, swallow, and even palliative care involved, sometimes early on, can be really key to maintaining both someone's independence, as well as preventing major issues like pain. Things you want to avoid are falls, aspiration, okay? So I'm going to shift gears. I'm going to come back to like the Parkinson's sort of pathology and talk more about those Lewy bodies, which have a lot of alpha-synuclein in them. So this is another very common atypical Parkinson disorder called multiple system atrophy. It's really a cousin of Parkinson's disease. It's similar in terms of prevalence as PSP. It's probably the second most common atypical disorder that we see in our clinic. Prevalence being around 3 out of 100,000. So again, about 20, 30,000 patients in the United States. Onset is a little bit younger, so roughly in the median sort of 50s. Now, MSA, or what's called multiple system atrophy, has a number of different faces, and it actually has a few older names to it, some terms that you probably may have heard in the passing. We don't really use these names, but Shy-Drager, striatonigral degeneration, and what's called olivopontocerebellar atrophy. Say that fast 10 times, but it's a mouthful. Now, why are all these old terms now and why we don't use them? Partly because we've learned a lot about the disease pathology, and all of these actually have a common pathology, and that is the presence of Lewy pathology in glial cells, surprisingly, compared to neurons. So they all look the same in terms of pathology, but they present slightly differently. And actually they present in a couple different ways. So two categories that we see of MSA. One is very, very, very similar to Parkinsonism or Parkinson's disease. The other one is a cerebellar predominant type of MSA. When I mean cerebellum is that thing that hangs off the back of your brain that helps with coordination, balance, speech. So people with cerebellar issues tend to look a little like they're slurring their speech and they have sort of a drunk walk, and their coordination is really off. That's not something we see in Parkinson's disease. Very different sort of quality of neurological deficits. So what's a key thing that goes along with these disorders? It's Parkinson's plus we call problems with the automatic nervous system, control of urinary, bowel, blood pressure control. The same thing goes with MSA of the cerebellar type. It always goes with autonomic issues, much more than what we see in Parkinson's disease. So just a little bit of a graph here showing kind of the different features. There's a lot of differences between Parkinson's and MSA, but I'm going to point to you sort of at these italicized things on the bottom of this list. The autonomic features, they're much more prominent. They're basically autonomic problems on steroids compared to Parkinson's disease. They're much more prominent. Levodopa, it's a Parkinson disorder. Their response is not as great, although many patients do get a good response. The dose needs to go up, but can cause abnormal involuntary movements we call dyskinesias and even possibly confusion. Unfortunately, rapid progression compared to Parkinson's disease is similar in this disease. So again, a shorter onset of, or a shorter period of disease, such as 6 to 10 years on average, although it can be shorter or longer as well. Now, there are other things that we see in this disease, for instance, earlier speech and swallow issues, significant sleep problems, sleep apnea, very common, but more common in this disease. REM sleep behavior disorder. This is acting out dreams. And I don't mean yelling or screaming in sleep. I mean actually kicking and punching to the point where, you know, sometimes the partner wants to go sleep in another room. Really severe patients with what's called REM. REM is the part of sleep where you're dreaming and you're just moving your eyes. But in this case, you're very active. Instead of moving your eyes, you may even be so bad in terms of the movements, you either punch the wall or even fall out of bed and injure yourself. Breathing problems can present in this disease, even early on, one of which is stridor, where you're really struggling to get a sort of a breath of air. And that's an upper airway constriction issue. And there are other features that are shown in this disease, particularly truncal postural issues, where the very stooped sort of person can develop in this disease. Okay, so there are differences that are prominent in this disease compared to Parkinson's disease. I do want to take a second to talk about the autonomic, we call automatic or autonomic symptoms that were present in MSA, because this can be a really, really disabling part of the disease, okay? So even if the Parkinson's part is not as prominent, this can cause significant disability. One particular problem that we see is blood pressure problems, particularly with postural or changes from going from lying to sitting to standing. We call that orthostatic dizziness, and in some cases, the blood pressure significantly drops. That's called orthostatic hypotension, okay, where the blood pressure drops on standing. Now, so normally when you stand up, you know, gravity takes hold, your blood goes from your brain down into your feet, but our body recognizes it. We have baroreceptors or pressure receptors that our brain recognizes and controls, and tells our heart to pump more and our blood vessels to constrict and to bring that blood back to our brain, otherwise we'll faint. In this disease, and in diseases that cause basically orthostatic hypotension, that doesn't really happen right, it's impaired. So patients, when they stand up, can really have significant drops in their blood pressure. Even 30, 40, even 50 or 60 points can drop on that top number we call the systolic number, making someone very dizzy or cause them to faint. Some patients don't faint, they just feel tired, maybe confused, feel this heaviness over their shoulder, we call like a coat hanger-like syndrome. They can just really cause us significant problems, inability to kind of get up, do any kind of activities at all, particularly if it's hot outside here in Florida, and you're dehydrated, spells disaster for these patients. Now, this can be treated. On the flip side, you know, there are other symptoms that can be seen. Urinary issues are fairly prominent. Urinary retention, overflow incontinence, urgency, increased frequency, and in men, erectile problems. Likewise, there are lots of other symptoms that are controlled by our brain that are automatic. You know, digestion of our food, Problems there can lead to gastroparesis, or feeling full quickly, or we call early satiety. And then on the other end, constipation, and if it's really bad, can lead to no control of bowels at all. Temperature just regulates, feeling hot or cold, changes in skin, you get a bluish skin, we call Raynaud's, and inability to sweat. So all these symptoms can be quite severe. Many of them can be treated though, and need to be recognized early on as part of this disease. So again, I'm just going to kind of go through some of the treatments really. It's a Parkinson disorder, so levodopa trials are warranted. Higher doses, try them. Certainly the problem here is the blood pressure problems. Levodopa can lower the blood pressure, and so can other, we call dopamine replacing drugs in Parkinson disorders. So a physician really needs to be careful and watch out for those symptoms. You can treat the orthostatic symptoms. There are conservative things you can do. Obviously, if your tank is dry, if you're dehydrated, no medicine is really going to work. So staying hydrated is job number one for most of my patients. Increase your fluids, maybe salt intake. You can wear stockings, although binders around the abdomen are much better actually. Sometimes this requires pharmacological or drug treatment, and a number of drugs listed here that can boost the blood pressure. So we're talking about permissive elevated blood pressure so that when you stand, it can drop a little bit, but not drop to the point where you fall out or faint, okay? Now, for all the other autonomic symptoms, there are issues. We can definitely treat the urinary symptoms, although they can become quite severe, treating constipation. Sleep disturbances often require a formal sleep study to really formally diagnose. So we do ask our bed partners to tell us, but sometimes they don't really know whether someone's stopped breathing or whether they do have active dream enactment, because they may be sleeping or they might be sleeping in a different room. So sometimes a sleep study is in order. Finally, really, the big partner again is the supportive care. Using our multidisciplinary team, physical, occupational, speech, and even palliative services are really critical, okay? Lastly, but not least, I'm going to come back a little bit to Parkinson's disease and talk about Parkinson's and dementia. So that's the other plus disease here. So as I said, Parkinson's disease can go along with dementia, but typically late, okay? In fact, it turns out that in Parkinson's syndromes, including Parkinson's disease, nearly 60 to 80% of patients do develop some mild cognitive issues, whether it's just slowed thinking, and up to 20 to 40 can develop significant dementia later on. And that can overlap dementias, including Alzheimer's, frontotemporal. So it can look very similar in some cases and sometimes be very difficult to distinguish. So the one type of dementia I do want to talk about at this point is what's called Lewy-Body Dementia, which is really kind of an umbrella term that includes two things, all right? It includes Parkinson's disease with dementia, which is late onset, and then this other form, which we call dementia with Lewy bodies, which is early onset, okay, which occurs usually in the first year or two of disease, okay, depending on how you define it. There's a bit of a spectrum, of course, but dementia with Lewy bodies is probably the most, or second most common form of neurodegenerative dementia compared to Alzheimer's disease. There are obviously other forms of dementia like vascular due to strokes and things, but this is a degenerative form. And its key feature is the presence of Lewy bodies shown here. And again, I'm just giving you the same pictures. So let me talk a little bit about this disease. There are diagnostic criteria for dementia with Lewy bodies. This is just from a published paper here, and I think it's actually really useful to kind of look at it briefly. I won't go through all of this, but I will mention that number one feature of dementia Lewy body is the presence of dementia. So this is a progressive cognitive decline that usually is executive visual spatial. It's very different than Alzheimer's disease where patients lose memory, okay? Now memory has different forms. It's sort of long and short. In this particular case, we're talking about if they have memory problems, it's short-term memory, working like memory, not the type of memory lost in Alzheimer's disease, which is that of long-term, or we call episodic type memories. But the key feature here is problems with we call executive function. That's doing daily tasks, organizing things, doing multitasking, common things we do, visual spatial, just being able to kind of organize and put things together. That is the type of dementia we see, and it has to be severe enough to cause functional dependence. Okay. Now, there are core features that go along with this dementia. One is fluctuating cognition or attention. So patients with dementia with Lewy bodies sometimes fluctuate, meaning they go through periods that may last for days, if not about a week or so, where they are just less, they sleep a lot, and they seem to have worse symptoms. They slur their speech more, they have more difficulty walking. But the big thing really is that they are cognitively less aware of what's going on and need more assistance. But these fluctuations, actually, they fluctuate, they go ups and downs, and essentially patients return to where they were before, despite all kinds of workups sometimes looking for infectious or other causes, but basically add up to nil. So these are cognitive fluctuations that involve attention alertness. Patients sometimes can have visual hallucinations, although not always. These are usually well-formed visual hallucinations. Remember this REM sleep behavior? So this sometimes can precede dementia, but it is a key feature, and then Parkinson's. So you really only need 2 of these out of the 4 to give you probable dementia with Lewy bodies. So you don't have to have all 4 of these core features to make the diagnosis. Okay, that is a key point of this slide that I want to point out. There are many other supportive features that are listed here, and then there are even some biomarkers for imaging shown here. Some things I'll point out here is there's similar symptoms that we see in other Parkinson's disorders. For instance, the gait problems, falls, blood pressure problems, autonomic symptoms can occur as well, as I mentioned before for MSA, so a little bit of overlap shown here, and even mood issues, particular apathy and anxiety, including depression. So it's not just the Parkinson's features shown here. This is the key feature is the dementia, and it happens early on. When you get dementia with hallucinations or psychosis, it spells essentially trouble basically for many patients, since they often end up needing a lot of care and sometimes long-term care when the 2 come together. So this is a devastating disorder. It is rapidly progressive, particularly for dementia with Lewy bodies, often misdiagnosed in the first few years. And by the time we see patients, sometimes longevity is only 2 to 6 years. It can be treated, of course, if recognized early. If there are Parkinson's features, we treat the Parkinson's, like I've mentioned before. If there are memory and thinking issues, which of course that's a key feature, we use medications like we use for Alzheimer's. And in particular, in this disease, sometimes these medications can be very, very helpful. So for a subset of patients treating with things like rivastigmine, donepezil, or Aricept, they can have a remarkable improvement in memory and thinking. Namenda, or what's called memantine, can also be used, and it has been shown to have pretty good benefit too for some patients. We treat the sleep issues and the fluctuations with supportive care. Hallucinations, if present, can likewise be treated. Now, I mentioned in the prior slide, some patients can have sensitivity to medications that are called neuroleptics or antipsychotics. Not every patient has that sensitivity, so it is worth trying to treat it, particularly when it causes significant distress. If patients up because they're seeing people outside maybe coming to attack them, even if they're trying to wander out of the house, that's when we do treat patients. There are good medications that are out there that can treat symptoms, and there's even new medication for Parkinson's disease and psychosis. So I do want to take a few minutes just to talk about the fact that with all of these syndromes, there are many features that we treat that are Parkinson's, and then there are lots of medications out there. We do have to think about balancing those treatments with some of the side effects. Parkinson's medicines like levodopa, as we raise the dose, can cause things like confusion. They can worsen the hallucinations sometimes. Levodopa frequently causes fatigue sometimes in some patients. And as I mentioned, for MSA patients can exacerbate the blood pressure problems. So it is really kind of balancing act and something that you work with your neurologist about. It really takes a village to treat these diseases. So that's why we use our multidisciplinary care model here at the Fix Ill Institute. Physical therapy is really critical to prevent falls, help with mobility, can help patients figure out whether they need a walker, a cane, or a wheelchair, for instance. Occupational therapy is for daily activities. So maintaining your independence. They can be extremely helpful to help inside the house as well as outside the house to keep patients independent. Our speech pathologists are experts in both speech as well as swallowing. So swallow issues progress in many patients and can lead to choking or aspiration where it goes down the windpipe into the lung and cause a reactive or just a pneumonia in patients. So anything we can do to help patients with their swallow, sometimes there are modifications, sometimes there are changes in diet that we need to make, softer diet, maybe pureed, thickening liquids, for instance. Nursing, of course, is really critical for many patients, and our social services. So it's not just the doctors. We play only one role here. We play a bit of the chief, but we really need to use our allied healthcare workers to help treat disease. Lastly, but not leastly, I just want to mention palliative care. It's really not just hospice. So the term palliative, means much more than that. It's a focus on comfort and quality of life, something that patients need to think about. What are their treatment goals, really? In some cases, pain and suffering really is the goal, and relieving that. Emotional well-being is another key role. Spiritual support for patients and even their caregiver. And then lastly really is sort of, how do you want to end your life? Our lives are only temporary, and ending your life on your own terms can be very important, and ending it in a dignified way. So talking about advanced care planning early on is something that we recommend. This is not about giving up. It's not about losing the care of your physicians. It's not about stopping all your medications. We can continue many of them. And it's certainly not about losing your doctor like myself in care when we talk about palliative care in patients. This is a key part of life, as well as your disease, something to discuss. I will end a kind of more of a positive note and just talk about some of the diagnostics. There's a lot out there. I've shown you some MRIs. We do have some new technologies out there like the DAT scan or dopamine scan that we use. This is just an example of the DAT scan. It's a functional scan. It looks pretty fuzzy actually, but we're looking for this comma shape. Parkinson disorders by and large look like this on the right, D. Unfortunately, this scan cannot distinguish between Parkinson's disease and any of the atypical disorders. It just tells you that you have a loss of dopamine, okay? But it can be useful to at least get us in the ballpark when we know that this is a Parkinson disorder and we can treat it like that. So it can be useful in some cases where we are confused and we're not sure what we're looking at. There are a lot of emerging therapies in Parkinson disorders. We are mostly about treating the symptoms these days, but there's a revolution going on, and we are starting to do research and bringing things into the clinic in terms of trials that are disease modifying. We have lots of ways to treat these symptoms, and we're trying to find new ways. We want to slow the disease. Obviously, we want that four-letter word, the cure. We're getting there, but we would love to have some way to slow disease down so patients can live well and independently, for the rest of their lives. There are ways to target these abnormal proteins. These are just some examples: antibodies, maybe vaccines to go after things, maybe repurposing some old medication that's out there that could really help this disease. These are good examples shown here. And then individualizing treatment for patients, really critical. Not every Parkinson patient, every atypical patient is different. So just some examples for PSP, cortical basal. There are lots of trials that have been out there. I hate to say a lot of this list is old, and many of these have failed, like CoQ10. The Dopamine trial failed. So far, some of these antibody trials have failed. But there's a lot of progress going on, and there are a lot of companies that are now really interested in targeting tau and targeting disease. So we are looking very closely at these trials and where they're headed. This last one we're looking at closely as well, and we're in planning phases for some of these. For MSA, this is just a short list here. There's things for treatment of blood pressure, there's disease modifying treatments, there's a lot of experimental stuff coming out. And then there's tons of research in the lab going on here. So this is not an exhaustive list, but I do want you to know tons coming. This is where we're at. We have a lot of different new drugs that are coming out that we're going to be trying. So let me finish here at the end of the hour. Just remember, not everything that quacks a duck is a duck, really. So not everything that looks like Parkinson's is Parkinson's disease. It may be an atypical disorder. So I talked about these atypical Parkinsons and some of the plus features. as well as some of the red flags and some of the pathology. There's a lot of overlap among the disorders, and even though we do have some pathologic hallmarks, some diseases actually have two forms of pathology in them, like Alzheimer's. You have both tau and amyloid, for instance. Just one example. With dementia with Lewy bodies, we have Lewy bodies and sometimes amyloid, so overlap with Alzheimer's. So there's a lot of overlap. There are treatment differences among these diseases, but one similarity or key features that you need to use a team. You need to get your allied healthcare workers and a multidisciplinary team together to treat these diseases. And then lastly, there are emerging treatments coming. I realize it's a little too late for some, but there's hope out there. So I'm going to end with that and take questions from those of you. I saw a bunch of chat messages coming up. So I'm going to turn it over to our hosts here. Shall I stop sharing? Yeah, I'll do that.
Yes, you can stop sharing. Anissa, are you having a hard time unmuting? Asked him.
Yes, there we go. It wasn't letting me unmute.
There you go.
Thank you. So we are at the top, so we don't have time to do a lot. I have one question that I think many people probably want to know the answer to, because they may not be somewhere there is a comprehensive center. So someone had asked earlier, the top 3 options in the country to go to for a consult and subsequent remote treatment via telemedicine, which is a fantastic tool that we have now available to us for MSA diagnosis and treatment, or any of the atypicals that you discussed. Do you have some recommendations for those?
So what I would tell folks really is that there are a lot of centers around the United States that now are great for this. Probably a good site that you can look at probably is the Cure PSP website. They list centers of care, and these are top centers. It's a foundation that really is out there to focus on atypical disorders, not just PSP, but cortical, basal, and multiple system atrophy. So it'll list a number of centers of care. There's some great centers throughout the country. Emory, is close to here. University of Alabama is close to here as well. There are a number of other great centers actually here also in Florida, like University of South Florida. You can get great treatment for some of these atypical diseases. Outside of that, I could point to a number of other centers around the country. But as a website you can go look at, that's a great place to get information. Pick your disease and look at the website. I would focus on that. For multiple system atrophy, there is the MSA Coalition website. It has some really wonderful information. For those of you who are thinking about dementia with Lewy bodies or Lewy body dementia disorders, look at the Lewy Body Dementia Association or LBDA Association website. It will list centers where you can go that are centers of excellence for care. And lastly, of course, you can send queries to me. I'm happy to point you in the right direction, or any one of us here at the center to help you out.
Awesome. Well, we are out of time. So I want to thank you so much for your time, your amazing presentation. We've gotten lots of positive comments just about how wonderful they love not only the information, but all of the hope that you've given in terms of what they're looking at in research and all of the new data that you've added. So I really appreciate your time, Dr. McFarland. And everyone that's with us today, if you could just give a wave of gratitude to Dr. McFarland for his amazing presentation. We thank you so much. You got a bye-bye sign from Phil.
You guys are,
awesome. I love it.
You guys are great. Thank you for joining me. I will look at the chat questions, and for those of you, maybe we can send them in. I can answer those.
Yes, that would be great. Thank you so much.
Thanks
Everyone
so much.
have a wonderful day. Thank you.